now we'll go for the first question. 68 years old male, 2 week status post left THA. Experiences a painful clang getting out of the bed in the morning. He is unable to bear any weight on the left leg. A radiograph is provided in figure A. Following close reduction and under sedation, the hip continues to dislocate with flexion up to 90 degrees. The hip is dislocating whenever the hip is flexing to the 90 degrees. So this is the image shown here. Each of the following operative interventions will increase the stability, except so we can look into which are the things. Revise the acetabular component to more medialized position. More medialized position will make the abductors lax and it will lead to instability. So it can be the answer. Then advance the trochanter means it will retension the abductor and it will lead to stability. Converting to a femoral component with extended offset, increased offset will lead to tension abductors and it will lead to stability. Replacing acetabular polyethylene with a constrained line. Constrained liner will definitely lead to increased stability. And replacing the femoral head with a larger size. Larger size head will definitely cause a high head to neck ratio and a high jump distance. So it will definitely lead to an increased stability. So we have to know that the stability can be increased by following ways: increasing the offset, advancing the trochanter, which increases the lever arm of abductors, and increasing the soft tissue tension, and increasing head neck ratio increases the range of motion to impingement, and we can use constrained liners. It will increase the jump distance. So we can see that in this image we can see that it's a larger head, it's a smaller head. So when the head neck ratio is increased, flexion or this jump distance markedly increases. So we can go to the next question. A patient comes to the office with a flexion contracture following a total knee arthroplasty that has resulted in unsatisfactory outcome. Intraoperative examination also reveals knee loose in flexion. So flexion gap is loose and there is a flexion contracture. Flexion contraction means there is a tight extension gap and a loose flexion gap. So one thing we can do is we can cut the distal femur. So extension distal femur only only imparts extension gap. So we can see that after increasing the extension gap, we can put a higher sized poly. So resecting the additional femur and upsizing the femoral component will be the best answer. Next question: compared to the cruciate retaining knee process, anterior stabilizer process has what effect on the contact area and what effect on the stability in PCL deficient knees. So in this case question, we have to know that there is a type of design that is called, this is the cruciate retaining design, this is the anterior stabilized knee. Anterior stabilizer design, there is a post like this thing anteriorly to prevent anterior translation. This is the anterior stabilized knee. So in this anterior stabilized knee, we have to understand that this is composed of highly conformed polyethylene component with a large anterior lip, which prevents the anterior translation of the femur on tibia. The high conformity of the polyethylene component increases the contact area of the implant. So the answer is 2. Increase the contact area and increase stability seen in anterior stabilized knee. So next question is: an active 73-year-old male presents with progressive pain and instability 15 years after undergoing a left TKR. He denies any recent trauma. Comprehensive workup of infection is negative. What is the most appropriate management of this patient? So we can see that diffuse osteolysis is there. There is osteolysis in the condyle tibia periphery. There is osteolysis. So after ruling out infection, we definitely have to do a revision total knee replacement. So revision total knee replacement is needed in an osteolysis, aseptic osteolysis. Osteolysis occurs as the result of foreign body response to particulate wear debris from the prosthetic joint. These particles consist of polyethylene, PMMA, and metal, all of which have been shown to elicit a distinct inflammatory response. Next question is: figure A and B are the radiograph of a 66 years old female who underwent an uncomplicated right HR through a direct lateral approach 3 months ago. Comparing the patient's pre- and post-operative film, you recognize that femoral offset was decreased by 2 mm, but her leg length was increased by 3 mm compared to the pre-operative films. Based on the current radiographs, which of the following is this patient's most likely to exhibit? AP looks okay. Lateral, we can see that there is an anterior overhang of the acetabular cup. If there is anterior overhang of acetabular cup on lateral view, cross-table lateral view, we can see that iliopsoas tendon will be going like this and getting inserted onto lesser trochanter. So it can cause iliopsoas tendinitis. So this is iliopsoas tendinitis is the answer. This treatment consists of either acetabular revision or transection of the tendon. For the diagnosis, we can diagnose as a diagnostic and therapeutic procedure. We can inject steroid into the iliopsoas tendon sheath. So next question. What is the most accurate description of the relationship between gender and knee loading during landing play while playing basketball? So females have a greater total valgus knee loading. That's the answer. We have to understand is that females landed with greater total valgus knee loading and a greater maximum valgus knee angle than male athletes. So increased dynamic valgus and high abduction loads were at increased risk of anterior cruciate ligament injury in female athletes. Dynamic valgus loading is seen in female athletes. While performing a cementless total hip arthroplasty, healthy 68 years old female surgeon notes an audible change while impacting final broach. The broach is removed and 1 centimeter longitudinal crack originating at the calcar is visualized. Bone stock is otherwise preserved. What is the next best step in management? So 1 centimeter longitudinal crack is there. So we have to classify it as Vancouver class. In the Vancouver classification, you have to learn the Vancouver classification intraoperative and postoperative. It's a 1 centimeter only. First, we can apply the encirclage wire, insert a standard press fit stem, and we can start weight bearing as tolerated postoperatively. So you have to understand the intraoperative periprosthetic femur fracture classification. Dictated with fracture location, bone quality and bone stability. Minimally displaced fractures at calcar includes in type A2. Occurs most often during broaching and managed with the removal of the broach, application of the circulage wire around the fracture, followed by insertion of the implant. Weight bearing does not need to be restricted postoperatively. So this is a type A2 Vancouver, intraoperative Vancouver. So we have to do this thing. So next question is, all of the following are contraindications of medial unicondylar knee UKR. Contraindications of UKR. Flexion contraction greater than 10 degrees definitely a contraindication. Varus deformity greater than 10 degree not correctable with the stress testing is a contraindication. Lateral joint line pain is also a contraindication. Rheumatoid arthritis is also a contraindication, but osteonecrosis of medial femoral condyle is not a contraindication of UKR. So we have to understand contraindication. Inflammatory arthritis like rheumatoid arthritis, fixed varus or valgus deformity more than 10 degrees, flexion contraction more than 10 degrees, less than 90 degrees of flexion preoperatively. ACL insufficiency nowadays considered as a relative contraindication. Significant arthritis in other compartments, joint subluxation more than 5 mm are currently considered as the contraindications of UKR. So which of the following variables is associated with elevated serum metal ions in metal-on-metal hips resurfacing arthroplasty? So we have to know the factors that causes increased metal ion level in metal-on-metal hip resurfacing arthroplasty. So there are two things that we have to understand is that smaller implant diameter and smaller femoral head diameter is associated with the elevated serum metal ion levels, metal-on-metal arthroplasty. Metal-on-metal resurfacing arthroplasty has high advantage of better wear properties. It has got both lower linear wear rate and both lower volume of particles than metal-on polyethylene. However, we have to understand that smaller implant diameter and acetabular cup abduction angle more than 55 degrees are associated with elevated serum metal ions. Greater than 55 degrees abduction will lead to edge loading and increased metal ion particles. This is an image of metal on metal resurfacing arthroplasty. Last question, 10th question. This is the image. First we can see the image. It's a failed acetabular component on both sides. So 58 years old patient who underwent bilateral hip arthroplasty 12 years ago now reports in pain in hips and difficulty with ambulation to the point where how he now uses crutches. A radiograph of the hip and pelvis shown. Figure out what is the best treatment option. Definitely in acetabular failure we have to go for a revision hip arthroplasty with cementless acetabular component. Cemented is never suggested in THR because it doesn't give a long-term good outcome. Bipolar is not indicated. Revision with an impaction, we can do a bone grafting without a bone grafting considering the intra-op situation. Cemented is not indicated. So the answer is the radiographs reveal acetabular component failure with bone loss. There are several treatment options. But the best option for servo your ship is cementless porous coated acetabular component with bone grafting. So cementless porous coated acetabular component is the answer.